In this video of fluid misdirection syndrome, the nucleus emulsification proceeded normally. It was during irrigation aspiration, the pressure started rising. The AC became shallow and it became difficult to continue. There was a risk of PC rupture and related problems. It was decided to stop IA. The viscoelastic was injected. You can see the visco being ejected out because of raised pressure. The interior chamber was re-deepened in a guarded way, taking care that there was no prolapse of iris. The intraocular lens was then somehow implanted into the interior chamber. The iris at this stage started to prolapse from the main port. The iris repositor was used through the side port entry. The posterior lip was depressed to decrease the raised IOP. The repositioning of the IOL was done simultaneously. The posterior lip was further depressed to help visco extrusion. The iris was reposited back and posterior lip was simultaneously depressed to allow visco removal and decrease of the IOP. Air injection was tried through the side port for deepening of the interior chamber. This was another difficult process. Once the AC was deepened, the speculum was removed. There was no VR support. Suprachoroidal hemorrhage was ruled out. Fast influx of 200 ml of IV mannitol was given. The patient was again taken up. The cornea was tapped and IOP was found to be normal. Visco was injected. Intracameral adrenaline was injected for pupillary dilatation. The air in the AC was managed partially with visco substitution. The next issue was moving the IOL into the bag. Luckily, the pupil dilated sufficiently. The IA was used to aspirate the cortex. Gill's cannula aspiration was used to remove the lens matter placed between the IOL and posterior capsule. In the end, the IOL was well centered in the back.